Hello, this is a short video about side effects of braces. Before we treat you, we always give you a treatment plan and a paper about the side effects of the braces. There are several of them. Most of them can be controlled over good oral hygiene, and some of them, they are really in our responsibility, or they are just bad luck and the patient cannot control these situations. So let me go through these points. Caries. That's one of the points that is really under control of the patient. If you brush your teeth nicely whilst you are wearing these braces, there will be no problem at all. And we always instruct how to brush. But it has to be done nicely. And then we don't have any inflammation of the gums, we won't get white spot lesions, discolorations of the teeth, we won't get caries. Pain is another point on this list. Pain will arise, especially when we put in the braces and when we make adaptations of the braces. There will be new pressure then on the teeth, and as soon as we put some new pressure, the teeth start to hurt, more or less. We cannot do much against that. You can take pain medication, of course. It's it's not a real side effect in a way that something will happen that lasts for a long time. It's just a short time discomfort. Recessions. What are recessions? That means the gums recede. So you have a nice line here between the tooth and the gums, and sometimes this line can go further down so that you see the root of the tooth exposed. That is something we try to avoid at all costs, but sometimes if we have a very weak gingiva, a very unfortunate biological situation from our point of view, then the gums can recede. What you can do to prevent that is, from your side, use soft bristles to brush your teeth. Keep them nice and clean so that the bacterial aspect of the inflammation is reduced or eliminated. And from our side, we have to do a correct planning. If we have lots of crowding in one arch, we cannot just align everything and push all the teeth out to the front. Then we risk recessions. Sometimes we simply have to extract teeth so that all the rest of the teeth can stay sane and healthy. Black triangles, that is related to the gum issue. So imagine once here we had a big crowding between these two teeth, meaning these two teeth, they overlap. Now if we align them, and in the end they will be positioned like this, nicely aligned, then where they were overlapping, we open a space. Here should be gums, should be gingiva. Now in young patients, that almost all the time happens, that these spaces that we open down here, they get filled up with gums, with gingiva. In adults, sometimes it doesn't happen. In a little, middle-aged adults like me, it often doesn't happen, usually doesn't happen. So if we correct teeth at an older age, then the biological reaction of the gums is not as favorable as if we correct them in kids. We cannot do much against that. What we can do, or the dentist can do afterwards, when everything is nicely aligned, we can reshape a little bit the teeth with composite materials to close these gaps, make the teeth a little less triangular, a little more rectangular. That's from an aesthetic point of view, it will look good, and it closes these black triangles a little. Next point, root resorptions. That means the root is getting shorter during treatment. Now this is a real side effect of orthodontics, and we cannot predict who will have root resorptions and who will not have root resorptions. Usually the root resorptions that occur are around 1-2 millimeters and are clinically absolutely irrelevant. You will never ever realize whether you have roots that are 15 millimeters long or like 14 or 13 millimeters long. Never. However, there can sometimes be, that is rare, but it can occur, sometimes be root resorptions even as strong as that only 2-3 millimeters of the root remain. And of course then the tooth starts to be really wobbly and it has a reduced life expectancy. We try to avoid that. We try to take X-ray, control X-rays if the teeth get really wobbly to check if it's the root length or not. In the worst case, we would have to stop the treatment. Fortunately for us, it really happens rarely. These are some single cases over 10, 20 years that you treat, some single cases that you have which show these root resorptions. Another issue that also happens rarely and is scientifically discussed controversially are teeth that die with pulpal necrosis during orthodontic treatment. It's not really clear whether they just die during the orthodontic treatment or whether they die from the orthodontic treatment. What is clear is that these are very rare cases. There are not many patients where we can observe that. Teeth do die also without braces. And if it happens, what has to be done is a root canal treatment, and then the tooth will most probably remain stable and good, functional for 1 decade, 2-3 decades. It can remain stable forever. If it doesn't, a single implant can be put in at this location so that you don't have a space in the end. As I said, this is controversially discussed. We are not really sure if there are pulp necrosis situations induced from braces, if they exist, or if they just happen during the time where someone wears braces. We don't know. Excuse me. Then, with some patients, when we have difficult occlusions, we need skeletal anchorage. These are tiny little screws that we can place here between the teeth or also on the inside, and of course we have to avoid the roots of the teeth so that they don't get damaged. We have to avoid the nerves so that those don't get damaged. And in a really adverse situation, one could actually hit or drill into a root. Now happened to me, and I think with the planning tools that we have with X-ray, where we can see how the roots are positioned, we can really reliably avoid it, but of course it could happen. And the last point that we have on that form is that in some patients we don't get to the result that we want to get to. This is mostly due to not enough compliance from the side of the patient. So the patient doesn't brush the teeth. At some point we feel it's too dangerous to leave them in place and we take them out to avoid caries situations. Or the patient doesn't wear rubber bands like instructed, and some occlusal corrections simply don't happen. These are the very usual cases if we have a malocclusion that cannot be corrected, or some teeth that don't move. However, there are some rare cases where teeth simply don't move. Due to trauma or to intrinsic bone metabolism problems, it can happen that a tooth is not moving, and there, at some point you come to the situation where you say, oh no, I've been wearing my braces now for 2 years and this tooth simply does not move. What can we do now? We need to replan to another solution. Luckily for us, this is really rare. So these are the points that we have on our form for your information. The ones who are really important, who happen a lot, are the ones that are in the hand of the patient, like caries, that you just have to brush your teeth. Like what I explained last, the situation that we cannot get to where we want to get because teeth don't move, because rubber bands are not worn. And the other one, which is relatively frequent, is the root resorption. But as I said, in small amounts. The ones which have a permanent effect on your life, they are really rare. And the rest, like the teeth die, that we get recessions, bigger recessions, that is rare. It can happen, but it is rare.